and we are going today to share with you a couple of presentations about calcific lesions that are right now one of our worst enemy when we are talking about complex PCI. So hopefully let's hope that the presentations of today will be useful and impactful for everyone. So the first presentation will be a little bit more philosophical, then we are moving to imaging, then we are moving to PCI itself. And the philosophical portion of the presentation is only, and we are going to discuss why, in our opinion, if you fail to prepare the lesion, you are prepared to have stent failure. So this is the key point of the presentation. So we all know that calcific lesions are a little bit of a nightmare for our patient and for ourselves when we are doing the procedure, because calcific lesions are linked to acute potential complications like neuroflow, perforation, dissection, and abrupt vessel closure. So when we are treating calcific lesion, we will have a higher rate of complication, but not only acute complication, because also the rate of chronic complications, so let's call it stent failure, will be increased when we are dealing with calcific lesion. So target lesion revascularization, target lesion failure, target vessel MI will be increased when we are treating calcific lesion. And in fact, there are two main mechanisms of stent failure. The first one is called organic or biological stent failure, and it's mainly linked to neo-intimal hyperplasia or neoatherosclerosis that may be fibrotic or calcific, is the same. And these two mechanisms are not linked to calcifications. But the other two, stent undersizing and stent underexpansion, that are called mechanical stent failure, may be or are linked to treating calcific lesion, especially the last one, so stent underexpansion. So our goal when we are treating calcific lesion is try to put down a well-implanted stent in order to reduce stent underexpansion, in order to reduce chronic events, so chronic stent failure. Because the thing that we want to avoid is doing something like this, to implant a stent in a non-prepared lesion and to end up having subacute stent failure and having potential complication even in the subsequent revascularization for correcting stent underexpansion. So the key point is that when we have to tackle calcific lesion, that is an aggressive disease, we have to be ready to have or to perform aggressive lesion preparation, aggressive therapies. So the background of it is that we are not always good at identifying calcific lesions, so we tend to underestimate the role of calcific plaques in our arteries, and in fact we know that angiography is not super good in identifying calcific lesions. While intravascular imaging, both IVUS and OCT are pretty good, especially OCT in calcium thickness, but also IVUS in all the other aspects, to identify calcific lesions. But not only identifying them, but also characterize them, because not all calcium is the same, and trying to characterize the calcium that we are going to tackle, it's useful in order to select the best tool for lesion preparation in order to have better stent expansion. In fact, this is a typical example. This LED that angiographically seemed pretty normal. In fact, when we performed intravascular imaging, in this case IVUS, it's a pretty calcific LED, mid-LED. So in fact, we have an eccentric lesion in the distal portion of the LED here at the level of the diagonal, and then a concentric calcification in the proximal part of the vessel where the lumen, to be honest, is pretty large. And this is why, so this is the reason why in the last European guidelines that were published last year in 2024 at the ESC, intravascular imaging was considered pretty mandatory for treating complex lesions, being them left main, long lesion, CTOs, instant restenosis, or even calcific lesion. But doing IVI, so doing OCT or IVUS at the end of the procedure is not the message of these guidelines. In fact, we have to use intravascular imaging in order to be prepared to choose the appropriate tool for lesion preparation. Because in a calcific lesion, in a calcific artery, probably there will be a lot of different calcific patterns coexisting. So we will have an artery with eccentric, concentric calcification, thick, thin calcification, deep or superficial calcification, or even nodules that are a little bit of a nightmare. And after identifying these patterns, we will be ready to choose the correct tool. Let's give you an example. So this is a pretty nasty RCA, to be honest. It's a bad RCA, super long disease, a lot of calcium, we know it. But look at the IVUS, we see that we have a lot of different calcific patterns. So not all the calcium is born the same or is created the same. Let's say not all the calcium develop the same. And I show you what the patterns are. In this long RCA, we have eccentric calcium in the proximal portion of the artery, then concentric thick calcification in the mid portion of the artery, and then once again in the distal portion of the RCA, a big eccentric calcification. And when you're doing like that, you have to be ready to identify your enemy and to be able to choose the correct lesion preparation tool. We are talking about balloon-based therapy or atherectomy-based therapy or IVL, that is still a balloon-based therapy, in order to have the best result. Because the thing that you want to avoid is, I show you, is to go on with balloons alone, because balloons alone are fine. You are going with bigger balloons, you are going with pushing with atmospheres, but worst case scenario, especially in eccentric calcification, is that you inflate your balloon, you increase your balloon size, you increase your atmosphere, and you increase your pressure, and then here, don't put, sorry. So you increase your balloon size, you increase your pressure, and then you can create dissection. That is not a big deal, because obviously when you have to treat this type of lesion, you accept dissection, but you can also create perforation, like in this case, because eccentric lesions need dedicated therapies, dedicated strategies, and we will see it during this presentation, during the next presentation, to be honest. So what we did in this RCA, since we saw that there were different patterns, was to start with an ablation, with an ablative technique, and so we started with orbital because the vessel was pretty big, and then we moved to IVL in order to tackle the eccentric lesions, and then only after a good plaque modification, we went with non-compliant balloons high atmosphere in order to complete our good lesion preparation and to be able to bring down the stents and to optimize the PCI. So the bottom line of this presentation is that imaging is essential when we have to tackle calcific lesion, and Jacopo will show us in the next presentation all about images, especially IVUS, in order to identify calcific lesion and characterize calcific lesion. But we have to change our mindset, because our goal is to achieve a good lesion preparation in order to reduce acute and subacute or chronic events, and sometimes we have to be aware that aggressive disease like calcific lesions requires aggressive treatment. Otherwise, we are going to do a bad PCI, and we are preparing ourselves to fail. We are preparing ourselves to have a stent failure. So, thank you very much.